Well, welcome, folks. We are admitting people from the waiting room, and we'll give people just a few more minutes to join before we officially kick off here. And we're going to ask that you each take a moment to drop into chat your name, hospital, and location, or name, organization, and location. And we'll get started here in just a moment. And then we're going to ask that everyone, we are using meeting rather than Zoom webinar. So if you can please mute your own lines, we'll go ahead and mute you on the back end if we start to hear some background noise. Great, and thank you to those of you who are already dropping in your name and location. Excellent. Arlene, welcome from CMQCC, and also our partners from the American Hospital Association. So glad that the two of you are with us as well. Hello, Brittany from Des Moines, and my three from Boston, Ariel from Texas, Austin. Nice to have you. All right. Well, we're expecting a few more folks, but I think in the interest of time, we want to go ahead and get started. So I'm going to turn it over to one of my colleagues at the Policy Center to introduce herself and kick us off.
Sweet. Thank you all so much for joining today. Excited to have you here. We're going to be having a roundtable discussion on hospital levers for change in maternal mental health. I'm Reagan Moss. I'm a policy and programs analyst at the Policy Center for Maternal Mental Health and a doctoral student at Tulane University. And I'll hand it over to Joy to introduce herself.
Hello, everyone. My name is Joy Burkhard. I'm the executive director of the Policy Center for Maternal Mental Health. Just a little bit more about our organization. Our mission is to close gaps in maternal mental health care. And we believe that two partners in particular, hospitals and payers, and of course, policymakers, I should say, play a critical role in closing gaps in maternal mental health care. So we're so glad that you're here today. I did also want to say that you can see in the image here on the right-hand side of our screen, that we center mothers in all that we do. And we directly serve not patients, but these 4 Ps, as we call them, policymakers, both state and federal legislators, members of Congress, and also agencies, so Medicaid agencies, public health departments, federal agencies like CMS and HRSA, just had a call with them today, policymakers, payers. So we already mentioned insurers, so commercial insurers, Medicaid agencies, and large employers, for example, are payers. Partners, that's our partners at AHA who are here today with us, national nonprofit partners, regional and state backbone policy nonprofits are examples of our partners. Philanthropy fall into that bucket, and researchers, and then of course providers. And when we talk about providers, our main audiences in the provider community are hospitals and also obstetric care providers like OBGYNs and midwives, as we do much of our work centers around anchoring behavioral health integration into obstetric care settings and helping obstetric care providers screen, provide a brief intervention, care coordination, and referral. So a little bit about us. If you have any other questions about our work, you're welcome to email at any time. We'll have my email address up at the end of today's session. And also you can drop some items into chat as well. So I also just again wanted to encourage folks, if you haven't yet and you just joined us, please drop your name, organization or hospital, and location into chat so we can get to know you. We'll have a time to do live introductions here in a moment as well. Reagan, we can go ahead and move into the next slide, and I'll turn it back to you.
Sweet. So today, as Joyce shared, everyone will have a moment to introduce themselves. We'll also walk through maternal mental health and the state of maternal mental health within the US, and then walk through our hospital whole mom standards for maternal mental health before we get to the roundtable discussion and discuss people's interest in forming a learning collaborative.
Great. So now we're going to turn it over to all of you to take about 45 seconds to say hello verbally on camera if you're willing. We will start with the folks that we see first in chat, which happens to be our American Hospital Association partners. So very, I think, appropriate. So we're going to start with Aisha from AHA. Hi, Aisha. Good to see you on camera as well.
Hi, everyone. My name is Aisha Syed. I'm a senior program manager with the American Hospital Association. I'm out in Chicago, but we do have a team in Washington, D.C. At the AHA, we are always working with hospitals and health systems to figure out what are some of the best practices that they're using to improve maternal health outcomes. So we have also started working a lot on kind of recognizing those practices within the maternal mental health space. So we've done podcasts, case examples, webinars on this topic, and are always continuously talking to hospitals to see if there's opportunities to share the work that they're doing broadly. So I'm really excited to be on this call and getting to know all of you better and seeing if there's opportunity to collaborate in the future. So I'm going to turn it over to Julia, who's also from the AHA, to introduce herself.
Hi, everyone. Julia Resnick, Director of Strategic Initiatives at the AHA. I work closely on Aisha on all things maternal and child health, including a focus on maternal mental health and really trying to raise awareness among our hospitals of opportunities for them to be more engaged and make sure that mental health is part of their perinatal care that they provide. So happy to be here with all of you.
That's great, and welcome you too, and so glad to be partnering with you. We're going to now turn it over to all of you who are representing hospitals and other organizations to say a brief hello. The questions again that we're asking are for you to answer are your name, your organization, the role that you play, and then are you working on maternal mental health yet in your hospital or organization, and then briefly describe what that might be if you are, and there's no pressure if you haven't adopted any practices yet. We know that's why you're here. So Brittany, I see you from Iowa up first. Do you want to turn on your camera and say hello?
Can you hear me?
We can. Hi, Brittany. And no problem if you don't want to turn the camera on either.
I was trying to, but
okay, there we go.
okay. So my name's Brittany Haskins. I work in, oh, there we go. You saw me. I do half day Friday. So I'm also decorating a nursery. And then I was like, oh, it's 2:00. So I am the childbirth and postpartum educator for the largest health system in Des Moines. I'm also the current chair of PSI Iowa. So I try to integrate MMH into everything that we do. I'm really educating providers, but we've also made a big push to incorporate it in all aspects of our childbirth education, letting them know that their hospital stay is not going to last forever. And so what can we do to anticipate them things before the baby comes for any sort of mental health issues for mom, dad, or any partners when they get home.
Great. Thank you so much, Brittany. And exciting to see that you're decorating a nursery. Seems very appropriate for our conversation. And stay well, right, with that note. Excellent. So I'll turn it over now to Marithi. I might be mispronouncing your name.
Sorry, it took me a minute to unmute myself. Yes, my name is Maitri Amarasekara. I'm a reproductive psychiatrist and director of women's mental health at Boston Medical Center and Boston University School of Medicine. And I'm a clinician, but I'm leading the integrated behavioral health programs in the OBGYN department, and also trying to provide some liaison between inpatient and outpatient in the for the OBGYN department as well.
Great. We need to clone you and put you in centers throughout the United States. I'm so glad that you're here. It's nice to meet you. Arlene, it's great to see you here. I'll turn it over to you to say hello next.
Thank you, Joy. My name is Arlene Cullum. I'm the Director of Special Projects for CMQCC at Stanford. And
Arlene, remind me what CMQCC is.
Oh, I'm sorry, the California Maternal Quality Care Collaborative. So we, among many, many, many other things, we receive data from maternity hospitals. We develop QI toolkits and hopefully affect positive outcomes in maternity hospitals in California. We also have a very large 5-year HRSA grant to affect, it's a maternal health innovations grant to reduce maternal morbidity and mortality in California. Maternal mental health is high on our list to work on with that grant. We also, about 1.5 years ago, my colleagues and I published in the Green Journal on addressing adverse adversities in both childhood and adult, and how to screen for that and what to do during pregnancy. So maternal mental health is very near and dear to my heart. So I'm very happy to be here today. Thank you.
Great. We have that study on our website, on our ACEs page, if folks are interested in learning more. And certainly, by all means, AHA also, Aisha, drop in the link to some of those great webinars. I remember the one with the Colorado program in particular that did some work around the adoption of the whole mom standards that we're going to talk about today. And there's probably many more resources on the AHA site. And Arlene, same, if there are other studies you want to drop in, or anyone else. I'm so glad that you're here. I think folks know that CMQCC has been leading much of the maternal mortality reduction work, or been a model for leading maternal mortality reduction work across the country. So glad you're with us, Arlene.
Thank you.
Next up is Ariel from Austin. I'll turn it over to you, Ariel. And Ariel, I don't know if you can hear me, but you are muted, and we can actually just come back to you, Ariel. We'll come back to Ariel. Next up, we'll have Lexi introduce herself from Harrisburg, Pennsylvania. Or Lex, I should say. Lex, there you are.
No, it is Lexi. Hi, I'm not sure if you can hear me.
Yeah.
Oh, hi. I'm sitting in I'm in the process of moving my daughter into her apartment at college. So I just grabbed an empty room, so a lot of echo.
Glad you're with us.
Yeah, thank you so much. Sometimes I don't even know how I end up where I am, but super excited to be present with you all. I oftentimes will say I'm just a nurse, but that is my primary role. I'm a labor and delivery nurse at UPMC Harrisburg in Pennsylvania, and I've been on the ground there for 18 years. I'm also an IBCLC lactation consultant. I am a nurse educator. One of my roles is I train all of the labor and delivery and maternity nurses on how to be baby friendly, because that was one of my babies at Harrisburg. One of the ways that I know that anything is possible, and I hold a positive attitude about making change in hospital systems, because if it can happen in Harrisburg, Pennsylvania, at our hospital, it can happen anywhere. I am, the chairperson of the steering committee, the education committee. I do all sorts of things. We also have an antepartum unit and one of the mental health. Well, it's a program we have, although I definitely
it needs to be more, but on our antepartum unit, we actually have, and it's not antepartum, it's postpartum, we do inpatient Zulresso treatments, which is very intense and something that I know that we can expand as far as especially educating and providing support for nurses and knowing how to best care for the patients that we have there. But I mean, we have them, our system, we have prenatal clinics, we have a lot of things going on. So that's me. Hi, nice to meet you.
It sounds like a lot going on. And if anyone has like overviews of their programs and what's happening related to maternal mental health that you want to drop into chat or share with us later, would love to get our hands on some of that. We're taking some notes as well, so appreciate that. Okay, let's see. We're going to turn it over now. Ariel's not able to say hello. Okay, no problem, Ariel. Appreciate that. Glad that you're here and able to listen. I will turn it over now to another colleague from Pennsylvania, Jennifer.
Hi, my name's Jen Peterman. My role is I'm the clinical practice leader on the postpartum unit at Hospital University of Pennsylvania. But I recently just graduated school with my psych and P, so hopefully I'll have my boards in a couple weeks. Really where we're at in kind of, we've got screening and identification of patients, but the follow-up is really where we are lacking as an organization. And really what I'm looking for is what are the best models out there? How do I pitch them to the hospital system in order to, make change? I'm a little bit with Lex. Like, I come from a baby friendly background, so I know change can happen, and can I institute change at my organization? So looking for some definitely models that have worked other places, so we can maybe institute them here. Like, innovation is really we're really value that at this organization. So whatever we can put in and I can put into place is really what I'm looking for. Great. So I'm excited to hear what everybody else has.
Yeah, excellent. We'll go over the standards that were developed by organization with quite a few players and stakeholders and hospitals over the years, called the Whole Mom Standard. So we'll go over those, which we believe, of course, are best practices, but we're really interested in getting feedback on implementation of some of the requirements as well. So glad you're here. Thanks, Jen. And let's see, Haley cannot hop on the mic, but Haley is from Oregon Health and Sciences University, the fetal care program, working on expanding perinatal mental health screening and intervention, I think in a hospital setting, as I understand. And Haley, I hope I'm pronouncing your name right. Awesome. I think we got everyone. So I also Rachel, I see you're on, so my apologies if I missed you. Anyone else? Rachel, I'll turn it over to you to say hello.
I'm Rachel Sheehan. I'm the Corporate Director for Women's Services for UHS of Delaware. We don't have any acute care hospitals in Delaware. I support 19 perinatal, neonatal services departments in 6 states and the District of Columbia. My organization has a behavioral health whole arm, and I'm trying to figure out how we integrate with them. So my facilities participate in the Premier Perinatal Improvement Collaborative that's sponsored through HHS. In that program, a very intensive assessment was done, and our biggest areas of opportunity are maternal mental health and substance use disorders. So we're trying to work on a plan on implementing tools. So I'm really excited to see the program.
Excellent. I had forgotten about that grant to Premier to support some of this work. So we'll have to talk a little bit more offline about how that's going. Would love to get some more background from you.
Absolutely.
Do you mind dropping your name and location and organization into chat too? We're going to save the chat summary to make sure that we've got everyone's names handy. So did I forget anyone else? I think we got everyone.
Yeah.
Oh, go ahead. Thank you.
Hi, Megan Trosco. I am the Director of Care Improvement at Arizona Hospital Healthcare Association. So we're also the AIM lead in our state. So that's kind of where we work closely with our PQC. But so I'm just here to kind of learn what's worked and what hasn't worked. We're planning to try to implement the maternal mental health and substance use disorder bundles starting 2025.
That's great. And Arlene, also CMQC serves as the state's perinatal quality collaborative. So glad you're both here. And Megan, good to see you as always. Megan, drop into chat for us your name, unless I missed it, location and organization, just so we've got that for the record as well. Anyone else that I missed? All right, I think we got everyone now. Also, hello to those who are watching the recording. There were about 40 folks that were interested, but not everyone could attend live. So welcome to all of you, and let's keep the conversation going. Feel free to email us at any time. Excellent. So we're going to move into the next slide. And we wanted to just do somewhat of a level set, if you will, on when we talk about maternal mental health at the Policy Center. What do we mean by maternal mental health? And wanted to start by sharing, and I think most of you on this call certainly know this, but that it's not just depression and it's not just postpartum. So many folks that are sort of new to the space often hear about postpartum depression first, which is okay. That's where most of the research was done initially, right? And that's starting to expand. So we logically tend to start there, but want to make sure everyone knows that it's not just depression. There's a range of disorders, including anxiety, which research shows is often a precursor to depression and is more prevalent than depression, both in the prenatal period, and the postpartum period. So anxiety is definitely something that we need to watch for, as well as a host of other disorders and symptoms, PTSD, birth trauma, right? When we're talking about hospitals, really important to understand, right? We hear the concept is that trauma's in the eye of the beholder, from Cheryl Beck, the leading birth trauma researcher in the United States. And so what may not seem traumatic during childbirth to us could be very traumatic to a patient and impact her mental health. How do we think about that as hospitals in particular, and mitigating the risk and potential for birth trauma? OCD, maternal OCD, we like to flag. Intrusive thoughts can happen to anyone, but when they become disabling, these are unwanted, sometimes scary thoughts about harm coming to the baby often. So when they become disabling and include some sort of compulsion or action the mom has to do to find relief from those thoughts, it's considered OCD. It's often misconstrued as postpartum psychosis because mom has scary thoughts. Psychosis is another really important disorder to understand. All of this is on our website. And just quickly to mention that psychosis is a break in reality. So hallucinations, delusions, paranoia. We liken it to being stuck in a bad dream, right? And you don't know that you're necessarily in a bad dream when you're in the bad dream, right? So very different than intrusive thoughts, scary thoughts, and OCD. Often confused, and often really horrible things happen to mothers who speak up about their OCD symptoms, being sent to ERs, right? And then being held for a psych eval, which might take quite a long time, stripped down with or without a phone, no access to her baby, and talk about trauma, right? So we just really want to make sure that folks understand the distinction there. We'll talk about ER protocols in a bit as well. So not just depression and not just the postpartum period. I think everyone's got that. All women are at risk, right? No one is immune from maternal mental health disorders, as we know, can happen to all women, regardless of income. But especially we see disparities, meaning high prevalence in Black, Indigenous, and other populations of color and low-resourced families. So I know that's not a surprise. More stress for whatever variety of reasons, and more possibility for suffering. And there's also disparities in access to care, which are the typical ones, as we all know, and sometimes added stigma in various cultures and ethnicities. So we'd like to also say that a screening, a piece of paper or a screening questionnaire on a app or digital page, right, is our only diagnostic right now. We're hoping that is not the case. We always say we don't diagnose heart disease through a questionnaire. Let's advance diagnostics and detection for mental health disorders, but we're not there yet. That is something to flag. And then the work that many organizations are really promoting, I think many of you have heard about behavioral health integration, and this is integrating screening and diagnosis and initial treatment plan development into primary care settings. A priority of CMS for quite some time, and others, and consistent now with what we're seeing within the American College of Obstetrics and Gynecology, who has been recommending screening by OBGYNs and other obstetric providers for quite some time now, and also released the very first set of clinical practice guidelines for maternal mental health last June, both for screening and diagnosis and also treatment. So a lot of effort to anchor detection in OB settings, obstetric care provider settings, OBs and midwives. There are some challenges with that, as folks know. And one of the big challenges that we want to point out are reimbursement considerations, that OBs are largely paid a flat rate once pregnancy is confirmed through the postpartum visit. So there's no incentive or providers aren't made whole for the time that they're needing to spend and we want them to spend. So it's a very big priority for us from a policy perspective. We have a new paper coming out next week on this. And also I wanted to flag, it's not here, that there's also new HEDIS measures. So some of you know about, well, I know you know about the Joint Commission standards all too well, and other sort of hospital-based standards. But HEDIS is used in an outpatient setting predominantly to detect screening in obstetric settings, for example. And that new measure, I think, was recently announced that it's now part of what Medicaid calls the core set. So the required measures that Medicaid has to implement. They're not required until 2027. So, but a lot of insurers are voluntarily beginning to report. It's hooked into what's called the National Committee for Quality Assurance accreditation standards for health plans. So there's some benefit to reporting early, even if it's not required by Medicaid for health plans through the accreditation process. It's not yet required by NCQA for accreditation, but there's some advocacy work happening to make it a requirement. So all those things I think are important to understand. We also heard about the AIM bundle, which if anyone has that handy can drop it into chat. I meant to drop it in earlier and to get a chance to, that would be great. So hopefully you are all very familiar with that. And if you're not yet connected and familiar, definitely take a look, and then also try to get connected with your perinatal quality collaborative. We know at least, I think 20 PQCs have identified adoption of this bundle as a priority. The last thing that we just want to acknowledge that makes this work difficult, and I know you all know, is the sort of the workforce shortages and shortages of referral pathways. And maternal mental health network adequacy. We do want to flag that there is now a credential that Postpartum Support International has developed a test so that providers now can earn what's called a PMHC, a perinatal mental health certification, which is really helping to address these treatment shortages and help us all easily identify who is appropriately trained and tested for core competencies in maternal mental health. We also have quite a few briefs on our webpage, including a fact sheet with some of these things. If you are interested in diving into any of this more, you can find more detail on our website. Any questions or comments about what I shared? I see no. Let me make sure. Anyone else? No? Okay, great. We're going to move into the next slide, which is just to share a little bit about what we've developed. Actually, it's been 10 years ago now, with funding from the Zoma Foundation, then the Walton Family Foundation, Ben and Luciana out of Denver, Colorado. I just want to thank them for the ongoing investment and understanding the role that hospitals can play in effectuating change in maternal mental health. It's what we call the hospital whole mom standards or hospital maternal mental health best practices. And so we developed quite some time ago and refreshed in 2023 these standards. I'm going to go through them in just a moment, but it's really used as a list for those of you in hospital quality improvement and program development to think about ways that you can effectuate change in maternal mental health. We're going to drop the link into chat so you can grab it now, and then I'm going to pull it up on my screen. So I wanted to share that, and let me go ahead and pull it up on my screen before you drop it into chat there, Reagan. Here we go. So here's our web page on the Whole Mom Standards. You can open the survey. We also have a soft accreditation program for those hospitals that do want recognition for the work that they're doing. That provides designations. So there was one hospital in Colorado and one in Illinois, and quite frankly, we have set the program aside for a variety of reasons and are interested in starting to really promote the opportunities here now that so many hospitals are ready with the AIM bundles and more. So you can see the designations here. And then I'm going to go ahead and open up the survey itself. All right, so here's what the survey looks like. And this, of course, doesn't have to be completed at the top. You can just use this as your own internal guide. If you're interested in this sort of soft accreditation and being recognized by the Policy Center as adopting the standards, then you would submit this full completed form with all the information at the top. So I wanted to go over these key categories of standards and first share that sort of the basic standards, like easier to adopt standards or where you might start, are shaded in white, and then advanced are in light blue. And so we'll go through all of them quickly, and then we want to open it up for dialogue at the end of this review. So one of the basic standards in white has to do with training, and that is that all nurses working in postpartum, labor and delivery, ER, NICU, or any other department that may work with perinatal women, also lactation consultants, social workers, have received a minimum of 3 hours of training from a recognized training organization like Postpartum Support International. There's others that PSI maintains a list for. So training of all the appropriate staff. Nurses, these are the advanced standards in blue. All nurses working in all those same folks have a six hours of training. Number 3 is psychiatrists trained in reproductive mental health are available or on call to provide treatment or consultation for severe cases like a postpartum psychosis, which we sometimes can see like immediately after birth is an example. Number 4, if the hospital is a teaching hospital, it trains resident students and postdoctoral students in maternal mental health. So some of these standards have an NA. So if it's not a teaching hospital, of course, that would be not applicable. Clinicians working in ER departments complete the Zero Suicide program for emergency room departments to understand core components of suicide risk assessment, including screening, brief interventions, and safety planning. Really important, as we talked about earlier. Curriculum is the next section. This actually, I mentioned earlier, we noticed that this would be applicable for teaching hospitals, so we'll fix that, and it should be blue, so post-grand rounds if it's teaching hospital and maternal mental health. Number 2 for curriculum includes an overview of maternal mental health disorders in birth class curriculum. We just heard about one of our earlier folks who introduced themselves mentioned birth class curriculum, including signs, symptoms, prevalence, local treatment resources, and content should come from a recognized maternal mental health organization. And also there are clips from videos and documentaries about signs and symptoms, which are recommended for inclusion. The next bucket is resources, policies, procedures, and practices. So in white, sort of a basic component here is promotes and protects sleep on postpartum floors. Some would argue let's not limit it to postpartum floors, but that's basic requirement, including thinking about policies that are focused on housekeeping, engineering, food service. So how are we ensuring that women get sleep, since we know lack of sleep can trigger these disorders, and including mania and postpartum psychosis in women that are at risk. Number 2, materials and discharge packets include information about maternal mental health disorders, including signs, symptoms, etc. Number 3 is an advanced standard that a hospital would conduct universal screening of its birthing population at the time of registration on postpartum floors or at discharge. I will flag that we've heard that at discharge is not necessarily, you may not get valid scores. So we actually, or postpartum, you may not get valid scores for all the reasons you can imagine, right? And so we really like the idea of screening at registration if a mother hasn't already been screened by her obstetric care provider, which of course is the gold standard, and hospitals can start to support that work too. So just wanted to flag that. Really welcome your thoughts and feedback in chat or when we open it up for conversation. And if a patient scores positive, consult with trained staff to address immediate concerns, coordinate treatment plan development with the obstetrician, and direct to treatment resources that may or may not be available within the hospital. We'll talk about what those might be in just a moment. Number 4, conducts observation and screening of mothers during NICU stays. If you have a NICU of longer than 48 hours, results of screening and weekly discussions of mother's mood included in multidisciplinary rounds for NICU patients. Just realizing that rounds may not happen in all hospitals, so we'll make an adjustment there. We welcome your feedback on that. Also in this section, number 5, an advanced standard published maternal mental health telephone line, staffed by clinicians trained in maternal mental health to serve pregnant postpartum women. This actually should probably be modified now because we know that many states already have state consultation lines and are promoting the national maternal mental health hotline. So we may modify this one. There have been some hospitals, some of you probably remember the program out of Illinois that hosts this kind of line. So we'll take a closer look at this one to see about modifying it. Again, really welcome your feedback on that suggestion. Number 6, referral process in place for accessing inpatient treatment programs specific to maternal mental health disorders for the most severe cases. Someone mentioned infusion of Zulresso is now available, which is potentially linked to this standard, or could be. There's also now oral treatment. But so welcome your feedback on this one as well, and what might we modify. Also in this section under resources, policies, procedures, etc., number 7 says has measurable outcome goals for maternal mental health programs in the quality improvement department, monitors at least annually, and implements interventions. This potentially could be updated now too because of the AIM requirements that for continuous quality improvement. So I think it still works because it says at least annually, but welcome your thoughts on number 7. Referral process in place to local therapists and psychiatrists, which can be provided through telemedicine. So just to have processes in place. Again, keeping in mind that it's ideal to coordinate with the OB provider as the primary care provider during the perinatal period, particularly now with postpartum Medicaid extension in place. Less of those barriers are in place in the postpartum period now than used to be. Assess patient satisfaction with the birth experience. So this one, I think there's actually some joint commission work that may be happening in this space. If anyone's keeping up with where that stands, would love to hear from you. But we think this is really important, particularly around prevention of birth trauma or identifying traumatic birth, that the hospital has data on patient experiences. And so satisfaction might not be the right word. It might need to say patient experiences. But you understand the gist there. Number 10, hospital has maternal mental health clinical champion who facilitates all of the above, essentially, which would be most of you, I imagine, on this call. Number 11, provides a sample postpartum plan worksheet at discharge, shared with mothers that may utilize questions like the Artemis postpartum social support screening tool. We should actually link those resources here. They're all on our website. But just to get patients thinking about what kind of supports they should be putting in place in the postpartum period is helpful for hospitals to play that role. We, of course, think OBs can play that role as well, but much easier to work through hospitals on that front. And we're getting close to the end of this section. Number 12, labor and delivery and postpartum rooms have a 24/7 patient support manager available to support patients' needs and requests. I know some of you already have those kinds of programs in place at your hospital for any type of support. I know a hospital in Kentucky is doing really remarkable work. I'll find out the name of the hospital around labor and delivery and maternity care with a patient care coordinator specific to maternal health available 24/7. It's pretty remarkable. Number 13, an advanced standard has a maternal patient advisory council with a minimum of 3 mothers' families served by the hospital. Would love to get thoughts on this one. I think it's really interesting because PQCs are starting to do a little more work in this space potentially as well. But it seems important as an advanced standard for large hospitals at the very least. Okay, programs, and then we're almost done. New parent support group. So we know there are breastfeeding support groups, but often it's focused just on breastfeeding support. I think this could be a helpful support for patients. For 6 weeks, it could include breastfeeding, soothing babies crying, really important to reduce that stressor. Going over things like the importance of sleep and diet, and exercise, which is evidence-based, like yoga, the importance of social support. That could be offered online or virtually. Maternal depression, anxiety support group. Many hospitals already have these that are staffed by trained RNs or LCSWs that have their PMHC and sometimes a certified peer support specialist. Really a helpful way for hospitals to provide that support. And then 3 and 4, the advanced standards are about creating outpatient day treatment programs like IOP or PHP programs, and then 4 inpatient treatment programs. So there's, I think, 9 inpatient programs in the United States now. So of course, those are advanced standards that we want to recognize. That's a lot, and I'm going to stop sharing my screen and pop back over to see all of you. And actually, I'm not going to stop sharing my screen yet in case you want to. Did I not share my screen? I never shared my screen, but you all followed along, hopefully, because, well, I'm sorry about that. I thought I was sharing my screen. So hopefully you followed along, and I would love to just open it up for dialogue. I am going to share my screen now so we can go back if folks want to ask a question about anything that I shared. There we go. Any thoughts or questions about these standards? Anything really struck a chord with you? Either like, oh, I really like that, or wow, that would never work because of XYZ. Arlene.
First of all, kudos. This is just amazing. I mean, it reminds me in many ways of Baby Friendly. And it's, in California, we're lucky, as you know, that hospitals are required to do screening. But where we're seeing a lot of issues is that there's no providers. And I have 2 main questions for you. One is, what's starting to pop up is transitional mental health services. You know, having a large regional place for people to refer to, then they work out all the intricacies of trying to get a provider, because we have many counties in California that don't even have one provider. And I did discharge interviews 20 maternity hospitals, and so many of them told me we don't even have one place to refer a patient to in the entire county. So
I think that's like the reproductive psychiatrist angle. Is that right, Arlene? There's no reproductive psychiatrist.
No, there's no therapists.
No mental health therapists at all.
Yeah, no, not even mental health therapists, let alone ones that are trained in cognitive behavioral therapy, et cetera, et cetera. So I just want to know what your thoughts were if this transitional mental health services model is catching, nationwide, and if that's something to move towards. And then the second thing I had was we're working on a discharge toolkit, and we're finding that here, I'll ask my second question after you answer the first one.
Yeah, I would wonder if anyone else has heard about these transitional, what was the phrase that you used? Transitional.
It's like transitional mental health services. So it's taking there's a reproductive psychologist that oversees other therapists, and they take patients from, like a 5-county area.
Okay.
And they're looking at maybe expanding. And I just didn't know if there are other models like this elsewhere in the country.
I have not heard of this, and so I love this. Is why it's so fun to have a roundtable, right? Because collectively, everyone's got so much knowledge. So I wonder if anyone else has heard of this, and we are going to take note and start to ask Arlene. I'll see if I have heard, in our larger circles.
Well, I can maybe follow up with you later on the couple different programs that I know about in California. My second question then has to do with a big thing that we're finding is the hospitals do the Edinburgh, whatever assessment they do. And then it's kind of like, oh, they get an 8, they're sub-threshold, but we know that those women get into trouble in the next couple weeks. And so we feel like very strongly we're working on a project with, to look at the ACEs, the adverse childhood events, stress busters, which are very similar to some of the areas that you've chosen here, but to do handouts for women so that they can be given prior to discharge on these areas of how to really reduce their stress, take care of themselves. Maybe they're not at a clinical level yet where they would bing, 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 need a referral. Anyway, I just want you to know we're working on those, and I think it's really an important element to include other things other than sleep. Anyway, I'll stop there.
Yeah, that's great. Love it. So we'll keep talking, Arlene. And when you talked about county gaps, I just wanted to flag for everyone on the call that there's a risk and resource map on our website. It's called Resource Shortages. It also, though, talks about risk by county. And so the dark counties here are risk based off of research that Deepika Goyal, some of you know, did to predict postpartum depression specifically. And so things like single marital status or age, as resource or risk predictors. So the darker the county here, the higher the risk. And then the bubbles represent providers these are maternal mental health specific providers. So reproductive psychiatrists, and PMHCs. And then we also have included a list of university-based centers that the Marseille Society of North America has identified as providing maternal mental health services. So all those bubbles represent those providers. And so just wanted to make sure everyone knows that this is available. Might be interesting to make the case for more work at your hospital or in your state. And then, boy, there was something else you said. I did want to just mention that the ACEs work around prediction of those who don't score a 10, which is often the cutoff in both the PHQ-9 or the Edinburgh screening tool, like what should we be doing there? I'll just flag, we are working on a pilot that I'm just trying to find, where is it on our website? I think it's here on our collaboratory page. So we're working on a pilot that embeds community health workers in OB clinics to do screening, brief intervention, and care coordination. It should be linked here, but we have this project is kicked off with the Common Spirit, another hospital system, but they also have OB clinics, actually Arlene in California, and in Texas. So in Austin, our folks in Austin, the site in Houston is likely to launch later this year. So exciting to see that. But one of the workflows is to provide brief intervention for patients who don't meet clinical threshold, like a 10, to your point, Arlene. So it's very similar to what I think you called the stress busters from your study, or
ACE's work, yeah.
Yeah, and so we'll share that. We'll make sure we share that those workflows as they're developed. Anyone else? What jumped out at you in our remaining 7 minutes here?
I hope I won't take 7 minutes, but I what I was thinking about, I just wanted to add, I think the stepped care model is really useful, and we also try to, if people are sub-threshold on screeners, to refer them to support groups that we have, or like, language-based support groups. We see a largely immigrant patient population that don't have English as the primary language, so it's harder to access the PSI groups or virtual support groups. And I do feel like social support is such a huge issue in perinatal mental health, and that can help and sort of be helpful preventatively as well. But the other thing I was thinking about was these acute services. Like, I'm from Massachusetts, we have a lot of hospitals and a lot of care and services, but we don't have inpatient unit for maternal mental health disorders in the whole state. Rhode Island is close by, so there is one, relatively close. And then I'm the psychiatrist in our perinatal addiction program as well. And there is treatment for perinatal substance use in terms of day programs and residential treatments, but we don't currently have anything we don't even have a partial that's focused specifically on perinatal mental health in a place that has a lot of mental health resources. So I think that is a sort of a challenging point. And I noticed that as well.
Yep. I'm gonna, you all get to see all my tabs and things, that I wanted to share one more resource. I think many of you probably know about our state report card, and just to flag that this is a resource that you can use. One of the measures in the state grade is whether there's an inpatient and an outpatient or outpatient treatment program. You can see the grades here of just Massachusetts is, even though there's been great work happening, is not scoring as high as some of the other states because of that gap. So just wanted to flag that for you. You're all welcome to take a look here. Here's the highlights. This is our second year doing the report card. Great. Anyone else? There was something else I wanted to share, but I'll make sure I give you all an opportunity to ask questions.
Hi, it's Rachel. I just wanted to comment on the sleep factor, as we're seeing sleep become more and more of a challenge for new moms. And that's a result of a combination of things: the baby-friendly expectations, moving to couplet care, and actually doing away with nurseries completely and not staffing them. And then as our inductions become longer and longer after the ARRIVE trial, we have patients that are intrapartum for 3 days. And they're not getting a lot of sleep while they're being cervically ripened, then induced for over 24 hours. And then we expect them to breastfeed and be awake with minimal support. A lot of times their support team has to go home because they have other kids. So sleep deprivation is becoming a very significant concern in our patient population. And then the only other thing I want to share, and this may sound kind of negative, but I'm just going to be really honest and transparent. I'm struggling with my teams in terms of the total hours of education that are expected across all the different programs and bundles that we're trying to implement. And we just recently, my organization moved education into productive hours. And so now it's even more of a struggle. So I'm watching my facility-based leaders really struggle with trying to get any education done. So trying to look at constructive ways to get the content to the teams through micro learnings and things like that, instead of, while I truly believe it probably takes 3 to 6 hours to get the content that we need to get to the teams around this topic, how do we do it in smaller bites? Because if we ask them to sit down and do an hour module, and they have to do it while they're at work because they're not allowed to do it from home, blah, 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 there's all these rules around it. So they're not paying attention if it's an hour-long module at work. So they're not really getting the content that we need them to get. So how do we start doing more micro-learning around that? It's just what I'm seeing challenge-wise.
I'm sure everyone else loves both of those remarks. Thank you so much for sharing it. And I love the micro-learning concept. If anyone has thoughts there, what could that look like team huddles and like top of the meeting team huddles on all things maternal health, 10 minutes, every time. I don't know what those solutions are, but I think it's really important to flag, and we should tease it out in the standards that this doesn't have to be in chunks of continuous time, right? And perhaps the other feedback is, can we start at like 1.5 hours for that smaller end of education? I think that's very important feedback that you're sharing. There's just not capacity to do it.
Well, sorry, one quick thing I wanted to add in terms of extending education and access is this e-consult possibility, or like a phone possibility. So the psychiatry access lines do that for the state, but I started one within our hospital system for providers who are seeing pregnant patients and wondering about medication questions. So that's a way to get a little bit of education, but also having a forum for people to drop in and ask questions when they need to, rather than it being sort of delivered at a specific time, is another potential way of sort of expanding the education as well.
It's a bit related to number 3 here as an advanced standard, but you're saying like provide a little bit of training, perhaps not just when a doctor calls, but maybe there's some way. So that's really smart. I love it. Well, we're at the end of our hour, and so what we would like to do, Reagan, do you mind dropping into, actually, let me stop sharing. You can put the slides, drop into chat our survey. So we want to hear from you, our AHA partners and us. We've been collaborating around, should there be some learning networks here around going deep around these standards? What might that look like? And so we want to hear from you what would be helpful. So Reagan's going to drop that into chat. And then Reagan, once you do that, why don't you pop up the last slide, and we will make sure you have our contact information. I know you do have Reagan's at least, and I thought my email was there and it is not. So I will drop it into chat here in just a minute. But we just want to say thank you for being here. Thanks for the hard work and interest. And for those of you, Jennifer, I know you had some immediate thoughts and questions. Like if anyone has anything they want to work on immediately before we launch, hopefully with some funding based off of your survey results, right? Be able to obtain some funding to host a learning collaborative. If you have anything immediate that you would like some thoughts on, we're here to help, and we can help get you connected to others as well to get feedback and ideas from other colleagues. So don't hesitate to email and ask questions. All right. Yeah. And Arlene, I see that message. Would love to connect with you and anyone else on the line. And Megan is also starting to do some great things in Arizona. I just want to flag, we've had a nice consultation call focusing on pregnancy screening by OBs in pregnancy to kind of move upstream, and what hospitals can do to support that work and implementing the AIM bundle. So just wanted to flag that. We're all here, and I hope we can all get together soon in a learning collaborative, perhaps at the end of the year. So thanks, everyone. Don't be shy about staying connected. Oh, and I'll stay on for folks that want to stay on. We can stop the recording and I'll stay on for just a bit.